Welcome again to our second section of imaging anatomy course. Our second section is the imaging anatomy of the thorax. In the previous lecture, we have discussed the mediastinum, the pericardium, and the lymph node groups of the mediastinum. So today we will be discussing the cardiac chambers, valves, arteries, and veins. So it's mainly the heart and the vasculature of the heart, including the coronary arteries and the cardiac veins. So today we are talking about the house of the love, right? Is it?
Yeah.
We think it is, but okay, what if somebody do heart transplantation? After heart transplantation, will he lose the feeling of love toward the people who loves?
Yeah, certainly not.
No, okay. Anyway, so talking about the cardiac anatomy, considering the imaging anatomy, is different from talking about the gross anatomy of the heart. Because we know that the orientations of the heart in human body differs according to age. For example, in young people, it tends to be more vertical. But then in old people, it needs to rest, right? Tired of working of decades. So it should be resting on the diaphragm. Another point is that when we say left atrium and left ventricle, right atrium, right ventricle, heart is not like a house. So the room on the left is on the left, or on the west is on the west. No, the left ventricle does not lie totally on the left. It is more posterior, left and right. The left atrium and left ventricle are more posterior. The right ventricle is not totally on the right, it's more anterior. It's actually the most anterior chamber. So when we talk about the heart in field of imaging anatomy, we need to have different windows to be looking at the heart. These windows are called the axes. So we have different axes of the heart. Let's have a look to this image. This is axial slices through the heart. This kind of imaging is done routinely in case of thoracic imaging, but not for the case of evaluation of the heart itself. So you see here that the chambers are not complete. The relationships between these chambers are not mature. The other structures of the heart, including the valves, the arteries, the veins, and so on, are not that much clear on these kind of views. So we need different views, different windows. The views that are used routinely for the evaluation of the heart are these views: the 4-chamber view, the 3-chamber view, the 2-chamber, and the 5-chamber view. So let's understand first what are these chambers that we are talking about. When we talk about 2-chamber or when we talk about 4-chamber views, we mean all the cardiac chambers, right? Left atrium, left ventricle, right atrium, right ventricle. When we talk about 2 chambers, so we mainly focus on the left-sided heart, because this is the most important part. It's the one that pumps the blood to the body circulation. When we add one on either the 2 chambers or the 4 chambers, it's the aorta. Yeah. So the 3-chamber view is left atrium, left ventricle, and the aorta, and the 5-chamber view is the 4 chambers of the heart plus the aorta. We start with the 4-chamber view, and we need to know how to obtain these kind of views. We will make slices like the previous ones in the heart, but then on the PAC system, when we want to evaluate the heart, we need to do some rotations of these views so we can look at these chambers. The 4-chamber view is achieved by rotating upwards from the apex on the axial slices. So in this axis, the right ventricle is projected next to the right atrium, and the left ventricle is next to the left atrium. Let's have a look to this view. This is a 4-chamber view. So here clearly we can see the 4 chambers: left atrium, left ventricle, right atrium, right ventricle. And if you notice, the relation is not that the left atrium is not totally on the left, right? It's the most posterior chamber. and the right ventricle is not on the right. It's anterior and it's at the center almost. So from this view, we need to know some other points. For example, if we are looking at a chest X-ray, and we want to evaluate the size of the heart, we need to know what are the chambers that are forming the borders of the heart. So the anterior border is formed mainly by the right ventricle. How we will see the anterior border? On the lateral projection X-rays, right? So on the lateral projection X-rays, the most anterior part of the heart is the right ventricle, and the most posterior part is the left atrium. So, for instance, if we see an obliteration of the retrosternal space, that's the space between the sternum and the heart, we may consider enlargement of the right ventricle. And if we see a compression on the esophagus, when we do barium mean and we see a compression of the esophagus at the level of the right atrium, we consider enlargement of the left atrium. And then the left and right borders are made mainly by the left ventricle on the left and the right atrium on the right. So when there is a deviation or there is enlargement or there is a change of the shape, the normal shape of these borders, we consider enlargement of these chambers. Other things about the four chamber view, that here we can see the mitral valve and the tricuspid valve as well, depending on the contrast protocol of the images. Another feature of this axis is that the apex of the heart is well demarcated. So this is the apex of the heart, and it is made mainly by the left ventricle. This was the first view. The second view is the three-chamber view, and now we know what are the three chambers, right? Left atrium, left ventricle, and aorta. So when the border between the mitral and aortic valve is localized on the axial slices, and the images are rotated from this point, the three-chamber view is then can be reconstructed. On this view, what we are supposed to see is the left atrium, left ventricle, the aorta, of course, and we see the mitral valve and aortic valve. This is a three-chamber view. So the left atrium, left ventricle, mitral valve is supposed to be here. This is the aortic valve, and this is the proximal part of the ascending aorta. The five-chamber view is the four-chamber plus the aorta. So in this view is achieved by rotating the four-chamber view a little more cranial, more up. This is the five-chamber view. If you notice, it's similar to the four-chamber view, except that we are slightly upper, so we can see the aorta here, the proximal part of the aorta. The two-chamber view are the left atrium and left ventricle. It's achieved by rotating the images perpendicularly to the mitral valve and parallel to the cardiac septum. In this view, in addition to the left atrium and left ventricle, we can also see the mitral valve, which is located between the left atrium and left ventricle. And this view is a good view for analyzing the ventricular function, especially that of the inferior and anterior walls. So for attaining functional data for evaluation of the left ventricle function, consecutive short axes must be reconstructed, making the use of three and four chamber views. This is the two chamber view, left atrium and left ventricle, and mitral valve. It's open in this view. Then we move on to talk about the cardiac chambers. We know that in the normal circulation, the venous blood is coming through the superior and inferior vena cava back to the right atrium, right? So when we are evaluating the heart and we are using contrast agent, the contrast agent is normally injected through the veins, right, intravenously, usually in the arm. So it will go through the subclavian vein to the brachiocephalic vein to the superior vena cava and then to the right atrium. So the first chamber that we will evaluate here, it's the right atrium, because it's the first chamber that is receiving the contrast agent. The right atrium has an anterolateral position in the heart and lies inferior to the left atrium. It has the entrance of superior vena cava superiorly at the roof and the inferior vena cava inferiorly. It has another opening, which is the opening of the coronary sinus, which is the venous return of the coronary or the cardiac veins. We will talk about it at the end of this lecture. Here we need to know that it is one of the entrances of the right atrium. It enters anterior and just to the left of the IVC. Let's have a look to the right atrium here. This is an axial view and this is coronal oblique view. So here we can see the right atrium, which is here. This is the IVC and this is the coronary sinus. Yeah. On the coronal view, we notice the SVC, the IVC, entering the right atrium. And we'll talk about some other structures of these veins shortly. First, we need to know this structure, which is called the crista terminalis. The crista terminalis is a muscular ridge that runs from the entrance of the superior vena cava to that of the inferior vena cava. What is the importance of knowing this structure? That sometimes and normally in most of the people, it looks like a smooth linear structure between the right atrium and the right atrial appendage. But this is not always the case. Sometimes it can be more rounded, simulating a mass. So knowing this structure is important to differentiate the normal variation of this structure from any mass at this location. Let's have a look to this structure. This is the crista terminalis. This is the right atrium and this is the right atrial appendage. So between the atrium and the appendage is this muscle. On the coronal view, this is it. It's extending from the opening of SVC to the opening of IVC. So it's this isodense structure. It's iso to the myocardium, right? Yeah. The right atrial appendage is a trabecularized part of the right atrium. It partially covers the atrioventricular groove and the right coronary artery that runs within this groove. So, anatomically, it is a flat and triangular in shape and contains small muscular bundles which run parallel to the atrium itself. So, we need to know these structures so we do not confuse it with any other pathology. This is the right atrial appendage. It's a 3D reconstructed image, and this is an axial image. This is the right atrial appendage. We move on to talk about the right ventricle, which is the second station of the blood and the contrast agent in our case. So the blood leaves the right atrium through the tricuspid valve, right, which has 3 leaflets and 3 papillary muscles. This is different from the papillary muscles of the papillary muscles of the tricuspid valve usually insert on the septum, which is different from the papillary muscles of the mitral valve in the left ventricle. We will know this shortly. The right ventricle is shaped differently to the left ventricle as well. The left ventricle is usually more cylinder in shape, and the cavity of the right ventricle is wrapped around the left ventricle. It has a thinner wall because it doesn't need that much pressure. We know that the pressure of the blood in the right-sided heart is lower than the left, right? Besides that, the left heart needs to pump the blood through the body circulation, which is not the case for the right ventricle. So that's why it has a thinner wall compared to the left ventricle. Another structure is the moderator band. The moderator band is a band-like structure that is running from the septum the interventricular septum, to the lateral wall of the right ventricle. This structure is important in electrophysiological conduction. Let's have a look to the right ventricle. This is the right ventricle. This band-like structure, which is running from the interventricular septum to the lateral wall of the right ventricle, is what? The moderator band, which is the electrophysiological conduction part. This is it on the coronal view, this band. Next is the pulmonary valve. After the blood has came to the right ventricle, then it needs to be pumped through the pulmonary artery to the lungs, right, to be oxygenated. So it goes through the pulmonary valve to the pulmonary artery. The pulmonary valve has three cusps. This is similar to the tricuspid and the aortic. So the only one with two cusps is the mitral. The others are all tricuspids. So the mitral valve sometimes is called the bicuspid valve. Another point that the pulmonary valve is separated from the tricuspid valve by a thick muscle known as the crista supraventricularis. This is different from the left-sided heart, in which the mitral valve and aortic valve lie side by side. There is no such structure separating the two valves. So here let's have a look to the right ventricle and the pulmonary valve. This is the right ventricle. This is the tricuspid valve between the right atrium and right ventricle. And pulmonary valve is almost here. This muscular structure between the tricuspid and the pulmonary is what? The crista supraventricularis. The characteristics of right ventricle that help differentiate it from left ventricle are listed here. But why do we need to differentiate? Is it much difficult to differentiate between left and right ventricle? In some complex congenital heart disease, yes, it's difficult. So we need to know the features that characterize the right ventricle from the left ventricle. One structure is the moderator band that we talked about, the band-like structure that is running from the interventricular septum to the lateral wall and responsible for the electrophysiological conduction. The septal papillary muscles, we said that the papillary muscles of tricuspid valve are inserted on the interventricular septum, which is not the case for the mitral valve papillary muscles. Another thing is the infundibulum. At the outlet of the right ventricle, this is infundibular structure, which is not the case of the left ventricle. And finally, there is no fibrous continuation between atrioventricular valve, which is the tricuspid valve, and the outflow trunk, which is the pulmonary valve. As we said, there is a crista supraventricularis, which is separating tricuspid valve from pulmonary valve. But in left ventricle, there is a continuation. There is a fibrous, sorry. Yeah, we will have some other images which will illustrate this point. We will have some illustrations from today's anatomy shortly. After the blood gets oxygenated in the lung, then it will be back through the pulmonary veins. So the first station of the oxygenated blood is what? The left atrium, right? Yeah. The pulmonary veins are usually two pulmonary veins on either sides of the left atrium. Then they are entering the left atrium. The middle pulmonary veins usually drain into the superior pulmonary veins. There are some variations in pulmonary veins. We will talk about them maybe in the next lecture when we talk about the great vessels and the anomalies of vascular system. Here let's have a look to the left atrium and the pulmonary veins. This is the left atrium. These are the pulmonary veins coming back, carrying the oxygenated blood into the left atrium. This is a 3D reconstructed image. So this is the location of left atrium, and these are the pulmonary veins that are carrying oxygenated blood back. The left atrium also has an appendage similar to the right atrium, and it also lies on the groove, the atrioventricular groove, and partially covers the left coronary artery in it. It also has small parallel muscles that are running vertically, so they should not be mistaken for thrombus. Let's have a look here to the appendage. This is the location of the appendage, and these small hypodense things are not thrombosis. They are the muscles of the appendage. Yeah. This is the appendage on 3D reconstructed image. As we see, it's covering the atrioventricular groove and a part of the left coronary artery. Why we need to know this? Because when assessing the coronary arteries, the left atrial appendage must be removed during the reconstruction of the images, so that we can see the left circumflex and the proximal left anterior descending artery. This is the left atrial appendage, and this is the image after removal of the left atrial appendage. Here we can see the left coronary artery, the anterior descending, and the circumflex artery clearly. The mitral valve is the valve that is between the left atrium and left ventricle. Now the blood is going from the left atrium to the left ventricle. This is bicuspid valve. It has two cusps. It also has annulus. The leaflets of the mitral valve are connected to the papillary muscles via cord-like tendon called the chordae tendineae. This structure sometimes cannot be seen on the images. The papillary muscles of the mitral valve insert where? Not in the interventricular septum, like in the tricuspid valve. Here it inserts on the lateral and posterior wall, as well as the apex of the left ventricle. And this is a feature of the left ventricle. Let's have a look to mitral valve. This beautiful image is brought from Grey's Anatomy. So this is the mitral valve with its leaflets. This is the left atrium. This is another illustration. Here clearly we can see the two leaflets, the anterior and posterior leaflets. And these are the papillary muscles. And these are the chordae tendineae that are connecting the cusps or the leaflets of the valve to the papillary muscles. There are these structures within the ventricle which is called the trabeculae corneae. Sometimes we can see them in the images. This is a superior view of almost all the cardiac valves. But here you need to notice that this is the right, this is the left. This is not the case of the imaging. In the imaging, at this area is the left and here is the right. Here it's the vice versa. So here in the left we see the mitral valve with its anterior and posterior cusps. The other valves are three cusps. So in case of tricuspid valve, we have the anterior, the posterior, and the septal leaflet. And the aortic valve has left, right, and posterior. The pulmonary has left, right, and anterior. If you remember that we said there is no fibrous connection between the pulmonary valve and the tricuspid valve, right? Now you know what does that mean, right? Yeah, because here you see that there is a fibrous, this left fibrous trigon, this trigon. It's connecting the valves of the left side of the heart. But in case of the right side of the heart, there is no direct connection. No. Our last chamber is the left ventricle. In normal situations, The left ventricle has a uniform thickness, varying diastolically from 0.6 to 1 centimeter. The blood enters the aortic valve via the left ventricle outflow tract, and there appears to be a fibrous connection between the mitral and aortic valve, which we saw in the previous illustration. Let's have a look to these images. This is an axial view. This is three-chamber view, and this is coronary reconstruction. Here we can see the left atrium, the aortic valve, almost the three cusps, and the coronary arteries originating from the right and left coronary sinuses. We'll talk about them shortly. This is the left ventricle. This is the outflow tract, aortic valve, proximal aorta. The aortic valve also has three cusps, as we mentioned, and another feature is that there is a slight dilatation of the aortic root. These are called the sinus of Valsalva or the coronary sinuses, because the coronary arteries are originating from them. It fills with blood during diastole, supplying the coronary arteries. The coronary arteries originate fairly cranially on the border of the ascending aorta. So, this is a three-chamber view. This is a coronal view. These are the dilatations or the sinus of Valsalva at the proximal part of the aorta. Aortic valve cusps are named according to their relation with the coronary arteries. So they are named the right coronary cusp, which gives off the right coronary artery, and the left coronary cusp, which gives off the left coronary artery, and the non-coronary cusp, which gives no branch in normal people, like the people who does not have any anomalies. So these are the three cusps: left to almost the left, right anterior gives the right coronary artery, and this is the non-coronal cusp. We move on to talk about the coronary anatomy. We know that coronary arteries are the arteries that are supplying the myocardium with the blood, and in case that there is narrowing or thrombosis, there will be ischemia and heart attack. So this is like a very important thing to be evaluated by images in cases of heart attack or suspected ischemia. Therefore, we need to know what are the branches and what is the normal of coronary artery and what is the abnormal. Normally, there are two coronary arteries. Left one that is coming out from the left coronary sinus of the root of the aorta, and the right coronary artery coming out from the right coronary sinus, as we mentioned previously. The left main coronary artery, or it's called the left coronary artery, immediately after the origination, it gives off two branches: left anterior descending and circumflex. The left anterior descending will run anteriorly and descends on the surface of the heart. So it will run between the two ventricles, the right and left ventricle. The circumflex will run posteriorly and laterally within the atrioventricular groove. We will see this shortly. The left anterior descending then gives several branches, including diagonal branches. They name D1, D2 according to the numbers, and septal branches, which are supplying the septum. The circumflex gives the marginal branches. They are named M1, M2. These are the ones that are supplying the margin of the left ventricle. The right coronary artery gives these branches, which are the acute marginal branch, supplying the margin of the right side of the heart. The AV node branch, supplying the atrioventricular node of the conduction system. And the posterior descending artery, which is the artery that supplies the inferior wall and the inferior part of the septum, the inferior wall of the left ventricle and the inferior part of the interventricular septum. This is in 65% of population, but in the left number of people, the PDA could be supplied by the left main coronary artery or by other branches. So the one that is supplying the PDA is the one that is dominant. Normally it's right dominant circulation. Less likely is left dominant. Less is the co-dominant. The two coronary arteries are supplying the posterior descending artery. This is an illustration of the coronary arteries. So we have the left main and the right. The left main then gives the left circumflex. This is running posteriorly and laterally, and this is the left anterior descending on the surface of the heart. These are the diagonals. And the left circumflex give these marginal arteries. On the right side we have this right coronary artery, which will then continue to give the acute marginal, posterior right, and then supplies the AV node and terminates as the PDA, the posterior descending artery. That was an anterior projection. This is right anterior oblique projection. This is the left anterior descending with diagonals, left circumflex with marginal arteries. Right coronary artery and acute marginal, AV node branch, and PDA. This is a lateral projection, left main, anterior descending, and this is left circumflex. On the other side, this faint one is the right coronary artery with its branches. Let's have a look to them on the images that we will need to evaluate. So we saw this image previously. Here we review the originations of these coronary arteries. The left main coronary artery is originating from the left cusp, or the left sinus of Valsalva, or the left coronary sinus. These all are the names of these structures. And the right one is originating from the right. After the origination of the left main coronary artery, it then branches into a left anterior descending, which will run anteriorly between the right ventricle outflow and anteriorly, and the left main atrium posteriorly. And this is the left circumflex. This is a 3D reconstructed image. This is the left, this is the right. This is the circumflex, obtuse marginal, and this is the left anterior descending, diagonals, and this is the right. The obtuse marginal is called obtuse because when it branches, it forms an obtuse angle with the main branch, and marginal because it's supplying the margin. This is the artery appendage. As we said, it covers partly the coronary artery, so it needs to be removed on reconstructed images. There is a branch called ramus intermedius. In 15% of people, this branch is coming out in between the left anterior descending and the circumflex. It's also called intermediate branch. It behaves as a diagonal branch of the circumflex. The left anterior descending travels in the anterior interventricular groove, as we said, and continues up to the apex of the heart. It supplies the anterior part of the septum, the septal branches by the septal branches, and the anterior wall of the left ventricle by diagonal branches. It also supplies most of the left ventricle and also the AV node. So the AV node can also be supplied by the left anterior descending. This is a mnemonic to remember the diagonals. That D for diagonals is originating from left anterior descending. This is the left anterior descending, running between the interventricular groove and supplying mainly the left ventricle. Yeah, this is two chambers. This is actually right anterior oblique projection. The diagonal branches that we have talked about, these come off from the left anterior descending, run laterally to supply the anterolateral wall of the left ventricle. The first diagonal serves as the boundary between the proximal and the second portion of the left anterior descending. So when we describe pathology, we use this as a boundary. So proximal is the proximal, distal is distal or mid portion. There can be one or more diagonal branches, as we said, D1, D2, etc. And these are the septal branches that are supplying the septum. The circumflex lie in the left atrioventricular groove between the left atrium and the left ventricle and supplies the vessels of the lateral wall of the left ventricle. Actually, knowing the course of these branches helps, because sometimes you have an image which have a projection that may be not described or maybe you are not very familiar with. So knowing that the circumflex it will be between the left atrium and left ventricle helps you to know that this is the circumflex. And the left anterior descending is between the two ventricles, the right ventricle and left ventricle. We talked about the obtuse marginal branches. In most cases, the circumflex ends as an obtuse marginal branches, but in 10% of patients, it has a left dominant circulation, as we said, in which the circumflex will supply the posterior descending artery. We move to the right coronary artery. It arises from the anterior sinus of Valsalva, or the right coronary sinus, through the right atrioventricular valve. So this is almost the opposite of the circumflex, right? The circumflex is in the left atrioventricular groove. This is within the right atrioventricular groove, between the right atrium and right ventricle. Yeah. In 50 to 60% of population, the first branch of the right coronary artery is the small conus branch that supplies the right ventricular outflow. In 20 to 30%, the conus branch arises directly from the aorta. We will see a case shortly. So this is the right coronary artery. Usually the first branch is the one that is supplying the right ventricle outflow. This is the right coronary artery originating from the right coronary sinus, running between the right atrium and right ventricle, interventricular groove, and covered partially by the right atrial appendage. This is the conus branch that we have talked about. In this case, it's originating from the aorta directly. On the left side here, we see left anterior descending. How we know this is the left anterior descending? Because it's between the ventricles, right? So the right ventricle, left ventricle should be here. This is the diagonals, the branches of the left anterior descending. This is the circumflex between the left atrium and left ventricle. In 60% of people, a sinus node artery arises as the second branch of RCA. First branch was the conus branch that supplies the outflow of the right ventricle. The second branch is the sinus node artery, which is supplying the sinoatrial node. But in 40% of population, the sinus node artery is originating from the circumflex, so from the left side. The next branches are some diagonals that run anteriorly to supply the anterior wall of the right ventricle, and the large acute marginal branch comes off with an acute angle and runs along the margin of the right ventricle above the diaphragm. The right coronary artery continues in the atrioventricular groove posteriorly and gives off a branch of the AV node. So supplying the SO node and the AV node. In 65% of population, as we said, there is a right dominant circulation in which the posterior descending artery is supplied by the right coronary artery. Then the PDA supplies the inferior wall of the left ventricle and the inferior part of the septum. This is the right coronary artery. This is the conus branch, which is the first branch, going inside and supplying the outflow of the right ventricle. This is the acute marginal branch, and this is the posterior descending. So this is a case of right dominant circulation. Our last part is the coronary anomalies. Sorry. There are several coronary anomalies, and they are slightly common. So we need to be aware of. The anomalies could be anomalies of the origin, anomalies of the course, or anomalies of the termination of the coronary arteries. The anomalies of the origin include anomalous origin of coronary artery from the pulmonary artery rather than the aorta. And this is a very dangerous one, right? Because, this is receiving deoxygenated blood. The blood that have less oxygen. So these people usually present with symptoms in the early life after birth. Another anomaly is the single coronary artery, in which there is one coronary artery coming off the aorta and then it branches into left and right. Origin from non-coronary cusp. This is the cusp of the aorta that usually does not give any branch. The anomalies of the course include myocardial bridging, in which the coronary artery is running inside the myocardium, deep in the myocardium. And what is the significance of this? That when there is a contraction of the heart, these muscles are contracting to pump the blood. They will compress the coronary arteries and cause ischemia. Another anomaly of the course is the duplication of coronary arteries. The anomalies of termination include coronary artery fistula, in which the coronary arteries are in continuation, maybe with one of the cardiac chambers, as we will see shortly, or with other branches. Extracardiac termination, the coronary artery in this case is terminating outside the heart. So let's have a look to these illustrations of some of these anomalies. This is a single coronary artery, right? Coming out from the right cusp, and then gives the left and right. The left is then running between the pulmonary valve and the aortic valve. So it is susceptible to be compressed at this location and cause symptoms. In some people, it causes sudden death. So this is a very sad and very dangerous variation. In this case, there is one coronary artery, gives of left and right, but in this case, it's running anterior to the pulmonary artery. Here it's running posterior to the aorta. The left one is running posterior to the aorta. In this case, there is a single coronary artery giving left and right, but the left one is now in continuation with the pulmonary artery, right? And then the left one is coming from where? From the pulmonary artery. Now the left one is coming from the pulmonary artery, in which it will have deoxygenated blood. So these are illustrations. Let's have some of the cases of these anomalies. This is a single coronary artery. Right coronary artery is okay. The left one is running between the aorta and the pulmonary artery. So it could be compressed here. So sudden death is frequently observed in these people. Another anomaly is the anomalous origin of the left coronary artery from the pulmonary artery. It's called ALCAP. It's the abbreviation of anomalous of left coronary artery originating from pulmonary artery. So here this is the pulmonary artery, and this is the left coronary artery. Pulmonary artery, left coronary artery. The right coronary artery is okay, coming from the aorta. Yeah, right one is okay, but the left one here is coming from the pulmonary artery. So it's receiving desaturated blood under low pressure. So the presentation usually within the first or 2 months of life with congestive heart failure. Here, this is the case of myocardial bridging. This is an axial view. This is 3D reconstructed. Here, the left anterior descending is running within the myocardium, deep in the myocardium. So it's susceptible to compression during contraction. This is left to right shunt. The contrast agent now is in the left heart, right? But we see there is a slight expel of contrast agent into the right ventricle here. So when we check here, we find that the large left anterior descending giving rise to a large septal branch that terminates into the right ventricle. Yeah. So this is shunting of the coronary artery to the right. This is left to right shunting. The cardiac veins are the veins that are receiving the blood then from the myocardium back to the heart. So there is the most important structure is called the coronary sinus. This is the largest vein that is receiving the blood from the great, the middle, small, and the posterior cardiac veins. Then it drains into the right atrium as we saw previously, between the tricuspid and the IVC. So this is an illustration of the cardiac veins. This large structure is the coronary sinus. It's receiving the blood from the small coronary vein, the middle coronary vein, or cardiac, and the large, the great cardiac vein, and the posterior cardiac veins. This is an anterior view. This is a posterior view. So this is the coronary sinus, small cardiac vein, middle, and great, this one, the longest one, and this is a posterior cardiac vein. This is a superior view. This is right, this is left. So this is the cardiac sinus, receiving the blood from cardiac veins and coming to the right atrium. The coronary sinus is running between in the atrioventricular groove on the posterior surface of the heart and enters the right atrium in the vicinity to the tricuspid valve. So this is the entrance of it. This is it on the coronal view. This is a reconstruction illustrating the course run by the coronary sinus here in the atrioventricular groove on the posterior surface of the heart, coming to the right atrium.